Has your loved one ever been hospitalized and had some loss of their cognitive abilities and abilities to function, either during or following the hospitalization? And this presentation is for you. We will talk about dementia and hospital delirium. I'm Dr. Deborah Beer, Director of Special Populations for ComForCare and At Your Side Home Care.
Thank you for joining us today. Our presenter today is Dr. Deborah Beer, PhD. Dr. Beer is the Director of Special Populations for ComForCare and At Your Side Home Care. She has a doctorate in therapeutic counseling and a certificate in gerontology, as well as 25 plus years as a psychotherapist and home care director of care. She's also had a part in the development of the ComForCare and At Your Side's proprietary training, Dementia-Wise. ComForCare and At Your Side Home Care is an international non-medical home care agency. We provide non-medical home care and companion and personal care services and specialize in delivering dementia care services. Here's Dr. Beer.
Today I'll talk about what delirium is and how it's related to dementia. We'll talk about how to reduce delirium risks and 3 interventions that are important in the hospital, and then delirium care. First, I want to say this presentation is for educational purposes only, and the information is not intended to be diagnostic or serve as a substitute for actual medical advice. Please seek help from a licensed medical professional for health concerns or diagnosis. Let's look at what delirium is. Delirium is a serious medical condition that comes on suddenly over days or hours, and it's associated with changes in attention, behavior, consciousness, and cognitive abilities. Hospital delirium is delirium that happens in the hospital. It's also known as ICU syndrome or acute confusional state. There are 2 types of delirium. One appears as overly alert and agitated behavior, and that's hyperactive delirium. Then there's the other kind that's lethargic and withdrawn behavior, and that's hypoactive delirium. Delirium has a varying course. People come in and out of it, or they go from hyper to hypoactive delirium and back again. What do these symptoms mean? Symptoms of delirium are a sign that there is an underlying medical crisis going on, and it has to be discovered and treated. Hospital delirium is very serious because it can result in death or serious disability, including greater cognitive impairment, muscle weakness, and that may be permanent, long-term, or brief or transient. In elders, the symptoms are often confused with dementia, even if little or no dementia existed before the hospital admission. Delirium happens outside the hospital too. It can happen as a result of infection, recent health changes, medication side effects, some kind of metabolic issue, or some other cause. The example that many of us are most familiar with is a urinary tract infection in an elder person can cause falls, cognitive impairment, confusion, even hallucinations and delusions. Once the UTI is treated, these symptoms go away. That's an example of delirium that isn't necessarily happening in the hospital. Let's look at how delirium and dementia are related. So let's look at who's most at risk. It's elders and those with dementia who are at most risk for delirium, especially in the hospital. Older adults with dementia who are at home, who recently experienced a change in their health, such as infection, surgery, injury, or a new medication, also have an increased risk for delirium. Family members and medical staff often assume changes in a loved one's behavior are due to dementia, especially if they are older. And this confusion can delay needed medical intervention. Delirium requires prompt diagnosis and treatment for the underlying medical issue. So how can people figure out if it's delirium or dementia? Well, the severity and symptoms of delirium can vary from person to person. So deliria can easily be missed, and it's very much underdiagnosed in the hospital. As a family caregiver, you know your loved one best, so you need to speak up when they're hospitalized if you see signs and symptoms that they're just not acting like they normally do. Let's look at some of the specific differences between delirium and dementia. One very important one is that delirium comes on in days or hours. Dementia takes months and years to progress unless it's come on because of a stroke or TIAs, which are small strokes. In delirium, there's a drastic, sudden change in cognitive function. In dementia, that change is usually progressive step by step. In delirium, there's new confusion and thinking and memory issues. Again, dementia is progressive, and the increased confusion is generally step by step. In delirium, there's new hyper-alert or unusually withdrawn, fleeting attention. And in dementia, people are generally alert and attentive from day to day with very little change, though recognizing everyone has ups and downs. Their problem is often with short-term memory, though. And in delirium, there is some other losses of function can happen, such as they become suddenly incontinent, or they have sudden mobility or language problems. In dementia, again, this is step-by-step decline unless it's brought on by a stroke. Let's talk about how to prevent or reduce hospital delirium. We need to be extra attentive and protective of people who fall into any of these risk categories. Age 85 or older, people who are impaired in more than one activity of daily living, people with visual impairment, people who have dementia or some other cognitive impairment, and there are many other risk factors, but these are some of the most important main ones when we're talking about people with dementia. More than 40% of seniors who are hospitalized will experience delirium, and that risk is even higher for people with dementia. Over 50% of those with dementia will have a delirium experience in the hospital. Most cases of hospital delirium are actually undiagnosed in the hospital. Unfortunately, after you've had a delirium experience in the hospital, there is an increased mortality rate for up to 12 months after discharge. 30 to 40% of delirium is preventable according to the methods that we know today. This is still an emerging field. The best treatment for delirium, however, is prevention. There is no way to directly treat it. The underlying causes have to be addressed, and then the delirium has to run its course. Early detection allows for more rapid identification of whatever the underlying medical cause is. If you're watching for delirium, you can pick up on early, subtle changes in the person's behavior that are indicative of delirium developing. Those changes need to be reported to the hospital. Let's look at 3 interventions for preventing delirium. These 3 interventions are correct medication selection, behavioral interventions, and environmental interventions. Administering multiple medications of any kind is always going to increase a risk for hospital delirium. And high-risk medications in particular need to be used very carefully, if at all, particularly in patients who are already at high risk for delirium. Let's look at behavioral interventions. These are best practices to prevent delirium, and they are still developing. You want to use person-centered care methods such as making a warm personal connection with the patient, avoid arguing, and respecting their personal preferences. We need to nurture their bodies. We want to make sure we provide adequate fluids and favorite foods to promote eating. We want to assist with feeding, but only if needed. We want them to maintain their self-care abilities and provide physical activity 3 times a day as long as it's okay with nursing and with physical therapy's guidance. We want to offer appropriate sensory and intellectual stimulation. And we want to evaluate and maintain adequate pain control because out-of-control pain is a risk factor for delirium. If the person uses dentures or bridges, we want to make sure they're available so that they can eat adequately. The third type of intervention are environmental interventions, and examples of that would be to maintain a day-night light-dark cycle. So quiet and for sleep and rest at night, and active and bright during the day. We want to reduce unnecessary and confusing noise day and night, and play favorite calming or energizing music, whichever the moment calls for. If the person's getting ready for their physical therapy session, we want to give them energizing music. If they're getting ready to take a rest or go to sleep, we want to give them calming music. We want to use greater than usual daylighting if the person has dementia, because people with dementia need 2 to 3 times more lighting in order just to function. We also want to make sure that they're using assistive devices if they need them, such as glasses and hearing aids, as well as the dentures, and an interpreter if there's a language issue, because we want to give them the kind of sensory stimulation that they need to stay oriented. We want to offer music, massage, and so forth to promote relaxation, because there's a lot going on in the hospital can cause them a lot of tension. And we want to use bed sitters to help either prevent or detect the early signs of delirium. A bed sitter is someone who sits at bedside where someone is hospitalized. They're someone to talk to. They're someone who can communicate information that's needed and also bring information back to the family. And there's someone who could be watching for signs of delirium if they're educated to do so. Family members are an obvious choice, but they have to have the appropriate temperament as well as the appropriate skills. Sometimes families stir up the person with dementia, and that's not what we're looking for. Some hospitals who are working hard to prevent and detect delirium early, they might have trained hospital volunteers or staff to perform this task for their most high-risk patients. Or you can use a specially trained agency CNA who might be subcontracted to the hospital or contracted to the family. You want to make sure whoever you use as a bed sitter will use dementia care best practices. Let's talk about the care that's required once someone develops delirium. Once delirium happens, it can't be treated directly. You only can treat the underlying medical crisis and let the delirium run its course. The care given should focus on treating the underlying causes and using best care methods for dementia or cognitive impairment. The American Geriatrician Society Choosing Wisely recommendation says that restraint should not be used in hospitalized delirium patients, and that includes both physical and chemical restraints. Instead, behavioral interventions should be used, and these are exactly what we're talking about. Once a person who has experienced delirium in the hospital has been discharged, there can be considerable impairment either in muscle strength or cognitive abilities. And their delirium symptoms may come and go for a while after discharge. If they're discharging to a rehabilitation setting, they may not rehab successfully, and they may have difficulty transitioning to the new care setting and accepting the therapies or care, and they may also fail to progress as much as others typically do in rehab. When they return home, they may be more disabled than before. They may need increased home care or other types of supervision, and they will have a higher risk for other illnesses and mortality for the following 12 months. And often the person and their family need psychological support. Seeing and experiencing someone who is hallucinating in delirium can be very traumatizing for everyone involved, including the person if they have a memory of it. So you need to be an advocate for your loved one and seek the kind of support that they need whenever you have signs of delirium, during delirium, or after delirium occurs. And remember that friends and family know the person best, so please speak up when the person is not acting right, not like themselves. Are you looking for more information about preventing delirium for your loved one with dementia? Or are you a healthcare professional needing to manage dementia care, caregivers, or families dealing with dementia? Our offices can assist with strategies and solutions for your dementia care needs. Contact your local ComForCare or at your side home care office for information about our dementia care services. And would you like to learn more about dementia-wise methods? There are many other than we've discussed today. Look for dementia-wise presentations and family caregiver support groups in your area held by our local offices. Sign up to receive more information about dementia care and other topics by going to our websites. Thank you for joining us today. If you're curious about reading some professional information about delirium and delirium care, here are some citations that I used to prepare this presentation today.